Doing it from the inside. I'm from the University of Virginia, home of great basketball. Now, actuaries tell us that our kids will not live longer than us. In this age of modern technology, genetic information, better medical care, our kids won't live longer than us. Why is that? Well, one of the major problems is obesity. When your body mass index gets over 30, it has consequences for your health. Now, I want each of you to look at 2 or 3 other people in the audience. The odds are, in the US, either you or one of the people you just looked at is obese. The incidence is 40% for women and 35% for men, and it's increasing every year. Even worse, when your BMI gets over 35 and you're severely obese, that has even more consequences for your health, and almost 10% of the population is severely obese in the US. Now, the medical community has not really done a great job treating the disease of obesity. We've done pretty well treating the comorbid medical problems. But when it comes to treating obesity, what's the common recommendation by most physicians? Diet and exercise. In fact, there is a multi-billion-dollar industry supporting that as the preferred treatment for patients with severe obesity. But this slide shows you what the effectiveness is. For a severely obese person to lose only 5% of their body weight and keep it off for a year, their likelihood of doing that is just 3%. So it's a whole lot of money being spent for not much results. But I guess one of the reasons for not having surgery is it's potentially, you could die from it, right? I mean, when you think about it. But bariatric surgery is a great treatment for patients with severe obesity. It works very well. It produces sustained weight loss and durable weight loss. We looked at our experience with gastric bypass patients 10 years out. They had still lost over 50% of their body weight and had improved every medical comorbid problem that we analyzed. But like I said, there's that concern about morbidity and mortality. And so let's just look a little bit about safe operations. So we'll say bariatric surgery 0.15%, and actually sleeve gastrectomy, which is the most popular operation, has an even lower percentage than that. But let's just use that number. So now, it's tough for me with the lights, but let's have a show of hands. Who in the audience thinks that elective laparoscopic cholecystectomy has a lower mortality rate than bariatric surgery? Any hands? Yeah, I see a few. Well, you're kind of right, but not completely, because it's about the same. Now, how about for appendectomy? Any hands? Couple? Nope, it's a little bit higher. How about for a non-surgical procedure like cardiac catheterization? Anybody? Yeah? Nope, it's higher. How about a really common operation like C-section? I don't see too many hands. I think you guys are getting the idea here. Knee replacement? Nope. Carotid endarterectomy? Definitely not. And colon resection, mortality over 10 times higher than bariatric surgery. But yet most of us, if we had our doctor told us we had to have one of these operations, we would get it done and we really wouldn't think twice about it because that's what we needed to get done. But maybe that's not true for bariatric surgery, and I'll get back to that in a minute. So the other thing about bariatric surgery is that it's transformative. I mean, the patients really undergo a metamorphosis. They can suddenly bend over and put their shoes on. They can fit through doorways. They can go to the bathroom on airplanes. They can go shopping for regular clothes. Job discrimination ends, and they generally enjoy a much better life. Take Sally, for example. She had medical problems, BMI in the 50s. She had a sleeve gastrectomy, and here she is a year later. Game changer for her. But now let's look at Margie. Also in BMI in the 50s, hypertension, sleep apnea, but unfortunately, she has a discriminatory insurance policy that forbids her coverage for any metabolic or bariatric operation. So she's been battling obesity for most of her life. It affected her dating life, it affected her job abilities, it affected her ability to raise her kids, and now is affecting her ability to be with her grandkids. And she faces more years of probably increasing cardiovascular problems, degenerative joint disease, and a potentially shortened life. And she can't afford the $28,000 it would cost out of pocket to pay for a sleeve gastrectomy. So what was she going to do? Well, fortunately, we did have an option for her. Endoscopic sleeve gastroplasty is an endoscopic procedure that reproduces essentially what a sleeve gastrectomy does by limiting stomach size. Now, I know maybe some of you don't know all about it, but I'm going to show a quick video to get you up to speed. If we could roll that video, please. Nope, back. Thank you.
The endoscopic sleeve gastroplasty is a non-invasive endoscopic procedure designed to reduce gastric volume. This animation provides an overview of the latest technique. A coagulation device, such as the argon plasma coagulator, is used to mark the anterior and posterior walls of the stomach along the greater curve. This creates a guideline for the first outer row of sutures. The first row of full-thickness stitches is placed from distal to proximal. A running triangular suture pattern alternates from anterior wall, greater curve, posterior wall, and is repeated for 5 to 6 bites. The anchor is then released and the stitching sequence is cinched tight. The triangular pattern is repeated. A total of 5 to 6 triangular running stitches are repeated in this first row. This suture pattern is designed to maximize the reduction in stomach volume and foreshorten the greater curve.
Okay, stop the video, please. Thanks to Apollo and the internet for that. So, what was Margie to do? I mean, she was interested in this procedure. She found out that it produces about 18% body weight loss, 3% complication rate, and was an outpatient procedure, and she liked all that. But the thing she really liked, the thing she really, really liked about it, was that it wasn't surgery. Which gets to the main point. Right now, despite all the improvements in bariatric surgery, all the safety, all the benefits, only 1% of eligible people every year have bariatric surgery. And that's been true for decades. Why is that? I mean, we surgeons have to realize that that's failure. We are not reaching the patients we need to get treatment to. And I've thought about this a lot, and I think it just basically comes down to one fact, and that is most patients who feel like they need to get something done for their obesity just don't want surgery. Now, that attitude may change. In my lifetime, our attitude towards cigarette smoking has certainly changed, but the aversity to getting bariatric surgery has not. And so, what can we possibly do to make a change? Well, here's one thought. I showed this slide to our county medical society a few months ago when I was giving a talk, and there was not one person in the room who could tell me why the incidence of gastric bypass went up so dramatically from 1999 to 2004. So I'll take anybody in the audience, just yell out the reason. I heard it, laparoscopy. And that was because, back then, patients perceived that laparoscopic surgery wasn't real surgery. It was different. You didn't get cut open for it. It was some kind of a new procedure. It wasn't really surgery. So, the perception, you can see the reality. Even the referring doctors thought that it was a lot safer, which wasn't true. So now, Margie's facing this situation. Is she going to get this procedure done? For her, because it wasn't surgery, she said, absolutely, I'm going to get it done. And so here she is, 3 months post-op, 37 pounds lighter, enjoying the benefits of the procedure. And so I think in the future will many other patients once this gets to be insurance approved. Now, it's not as good as a sleeve gastrectomy for producing weight loss at this time, but with improved technology, it might be. It's not insurance approved right now, but I think that's going to change in the next few years. I mean, after all, we have to invest our time and effort into procedures that will help increase that 1% rate. We've been thinking about it from the surgeon's point of view for way too long. We have to think about it from the patient's point of view and what they're willing to have done and what they're willing to undergo to treat their obesity. They've all been 97%ers. Very few percent have been 1%ers. And it's time to fix that. Oh, and for you bariatric surgeons out there, my advice is you probably should learn how to do this, because in a few years, you could wind up being like a surgeon who nowadays only does open cholecystectomies. Thank you. Have a seat. Okay, great.
Thanks, Bruce. It's terrific. And I think that slide that you show with the morbidity or mortality of all the different procedures, I mean, how many of us, when we're talking about we're consenting a patient for an appendectomy, would ever refer to it that way? Say it's a very safe procedure. It only has, 3 times the mortality rate of a gastric bypass operation. We would see everyone getting treated with antibiotics. So I guess, it's that same issue that Brent was talking about with that innovation. The endoscopic approach sounds wonderful. What do you, and of course we feel such a strong need to give our patients the latest and greatest, and how do you balance that interest in innovation? And all of us are innovators and early adopters, but how do we balance that with the lack of long-term data for the procedure?
Well, no question. I mean, I knew about this, and honestly, when I first heard about it, I was, a little skeptical about the durability of it, because there had been a lot of endoscopic mucosal procedures that had failed miserably. But then, when the 3-year data came out that the weight loss was sustained and durable, I thought, this could be a game changer. I thought that about lap chole, and I really still believe that could be true for this procedure. Now, we don't have, there's been 5-year data presented, but not published, and it's decent. It's running, most places are running over 15%, and most major series around 18% of body weight loss, and it seems to be sustained. It mostly occurs in the first year, but it's the regain of weight doesn't seem to be any worse than surgery for sure, so far. Now, but again, it's new. But what I think, what my main point is, we've been making surgery better for 30 years, but no, the patients don't want it. They don't want surgery. They want something different. And if they'll get something, if this will work for them, even if it's not quite as good, if this will work for them and help them and fix some of their medical problems, and if they get it done, God, we've done a good thing. I mean, we've got to do something to help more than 1% of people. We're just failing.
Bruce, what did it take for you to learn to do this? What was the journey like? I've known you forever. Half your practice is bariatrics. You told me that a long time ago. What did you have to do to get tuned up to do this?
Well, I think there's no question it's a learning curve. I've done about 24 of them now, because I only get a couple a month because it's not insurance covered. In fact, most of the patients I've operated on are exactly like that. The lady I tell, they didn't have insurance coverage for anything else, so they signed up for this. I'd say about 7 or 8 procedures before I really felt like I was doing it really well. I took a couple courses, took the training things that you need to do to practice on pig models for a while, did that. But there's actually one paper published on the learning curve that says after about 7 cases, your stitching gets a lot better and stuff. So, and there's nuances to it. I do it better now than I did the first 10, I'm sure. But I think that I'm doing a reasonably good procedure for folks, and like I said, I've done about 22 or 24 now. So.
If somebody has a question, if you just come on up to the mic, that would be great.
Nova Zoka from West Virginia University. Thanks for your talk. our we recently this fall hired an interventional gastroenterologist with experience with this, and he shared some nice data showing that combining the endoscopic sleeve with the GLP-1 medications increased the TWL from around that 18 to 20 to 28, so the same as the sleeve. And I agree, I think amongst a lot of surgeons, some people say, surgery all the way for obesity, but I think the ESG fills a nice hole from operative. You have now endoscopic, medical weight loss, diet and exercise, so it really adds to the spectrum. And yeah, thanks for sharing.
Yeah, well, thank you for that information on the medication. Certainly there are a lot more people using the GLP-1 agonists, and it does seem to be helpful. But, I mean, think about it. If you were in a position where you decided to get something done about your obesity, and you could have an endoscopic procedure with medication that produced essentially the same weight loss as an operation, you might go for the endoscopic procedure.
Bruce, do you have fear that in some ways this might turn into some of the horror stories we heard about banned clinics in LA that had to be shut down by the FDA? Certainly there are, when you're a hammer, the whole world looks like a nail.
Yeah.
Do you have fears that people with advanced endoscopic skills, but not really part of a bariatric program, will see this as an opportunity to make money?
Well, I really, that's why I'm advocating it for my bariatric surgery colleagues, because we come from a mindset of having a comprehensive program and following our patients and knowing our results. And, but unfortunately, like I said at the very end, right now, as I understand it, there's about 4 to 1 gastroenterologists to surgeons doing this, and I don't know that our gastroenterology GI colleagues come from the same mindset: long-term follow-up and comprehensive care with nutritionists and other aspects of care that the patients need. I think it needs to be done within a comprehensive weight loss program, absolutely. And I hope if it's insurance covered, that's a stipulation.
Yeah, I think that's key. In the next session, I'm the surgery rep to the AGA ESG registry. Will be presenting the first year data. So I think people have gotten that message that we have to follow the long-term results, but I sort of sit there as part of the group and wonder how many of those people are in comprehensive bariatric centers, and I couldn't agree with you more. It's more than a procedure; it's a lifestyle and a follow-up, and that it's one thing if a gastroenterologist joins a bariatric center, but clearly we don't want to turn this into the loss of endoscopy like we did 40 years ago. So I agree with your message completely. What are your thoughts, Dan? You do bariatric surgery.
Well, when my center recently, reapplied for MBSA equip certification, this is the first time that we applied to be a comprehensive center with medical certification as well. So as a surgeon, I think it's wonderful that we're now really participating with the medical doctors in addition to the surgical doctors to become a bariatric center of excellence. But I bring to the center all those biases that all of us surgeons have. That I look at the better weight loss with surgery and a chance to cut is a chance to cure. And I think we were kind of brought up with that attitude, and maybe it's going to evolve over time, and we'll have to be more accepting of medical approaches as the GLP-1 medications become more widely accepted and covered by insurances.
So like I said, we think about it from the surgeon's point of view, and that's what's got us stuck at 1%.
But I think when it comes to invasive procedures, having a fully tooled up surgeon who can sit there and I can do a bypass, I can do a sleeve, I can do an ESG, I'm going to try to find the right procedure for you, is a very different story than being a hammer and only hitting nails.
Oh, absolutely, yeah, absolutely.
Which is key. Well, Bruce, we are very grateful to hear your story. We're really enthusiastic about continuing to innovate along this line and sharing the experiences of your patients. Thank you so much.
Thank you.